तो उसमें कर देता हूँ फोन को फ्लाइट मोड में है।
Good evening, everybody. We are back again with our Dean Sir, Dr. Pankaj Madhukar Luka Sir, our Chairperson, Dr. Pawan Jethani Sir, and now, not taking much time from all of you, I'm handing over the session to Dr. Pawan Jethani Sir.
थैंक यू सर। प्रैक्टिशनर की ई पाठशाला में आप सभी का स्वागत है। आज हमारे साथ में डॉक्टर सुधीर कुमार शुक्ला सर हैं। ही इज वेरी सीनियर रेडियोलॉजिस्ट वर्किंग एट भिलाई। ही इज एक्स प्रेसिडेंट ऑफ IMA छत्तीसगढ़ स्टेट। ही इज फाउंडर president of IRA Chhattisgarh, and he is honorary professor Academy of Medical Specialties. He is examiner of DNB board also. I would request Dr. Sudhir Kumar Shukla sir to start the session, sir. Please.
Good evening, everyone. You're getting my voice?
Yes,
Sir. You are audible.
Yeah. Good evening, everyone. I thank you to Dr. Atul Deskar, professor and medical superintendent, to take that pains for practitioners ki Pathshala. Dr. Pawan Jethani, DMS, GMC Rajnandgaon, and Chief Coordinator Dr. Monica. I am thankful to you all, and thank you everyone. Good evening, my friends. We are just going to talk about chest radiology, how to read X-ray chest and beyond. This subject is very vast, and it is difficult to cover up in a small period of time. So, but we'll do the basics today. हम लोग आज थोड़ा सा basics करेंगे, and then we'll go in details in further sessions if you allow us to join, and if you give us opportunity. And I would first like to know from the students that many of them must have visited the radiology department for their own purpose or to help their friends or colleagues, and they know what radiology is. Because in their undergraduates, radiology में ज़्यादा कुछ होता नहीं है, but we start with the basics, and how we'll see the slides. I participated in conferences, but the question arises first, who invented the X-ray? Before going into the radiology and X-ray chest, we must try to understand how a little bit of who invented the X-ray. A preliminary X-ray was discovered in 1895 by German physicist Röntgen. They were called X-ray because they did not know the nature, what is unknown at that time. He was experimenting on the cathode X-ray tube, and which was suddenly he found that his wife's X-ray is radiograph, first X-ray photograph was shown on the wall. So he tried to find out what it is, how it is done, and then he worked on it, and this labeled as X because his nature was unknown. So XYZ, he labeled as X, and X-rays. That's how the first X-ray was shown by Bertha for his wife Bertha Röntgen, and in 8th November 1895. He got the Nobel Prize for this, and it is a very commonly used radiography. Is very commonly used. You can see here the majority of the investigations which we are using imaging modalities, radiography is 65%. आपने देखा होगा कहीं ना कहीं आपका एक्सरे चेस्ट या कोई दूसरे एक्सरे बोन में स्वेलिंग है, लिम्स में स्वेलिंग है, या दूसरा कोई प्रॉब्लम है, तो वी गो फॉर एन एक्सरे. So major bulk is covered by radiography, but these days also ultrasound and other modalities also coming up, and these models. So this is a basic where the small township and third tier city, we do this X-ray is always available, and we do mostly the radiography is the preliminary investigation. And why we want to discuss this? Why? Because everybody, whether it is a physician, surgeon, anesthetics, general practitioners, they try to read, they should know, because sometimes what happens, the film is available and the reports are not there. So basic things, we must know it. This is the X-ray tube. You can see here, the cathode and anode is there in this tube, and the rays, electrons are bombarding on the target on tangent, which is usually of tungsten, and these rays are emitting. And you can find out, you can see this, whatever comes in the picture, what has come on the way is image is created. And this is how the basic X-ray tube. We all know about it. And this is just, I want to tell you a basic AP view. You can see the anterior posterior, the back is in the contact with the plate, and the anterior part is facing the tube. Here the posterior anterior, the rays are coming from the behind, and front is in contact with the plate. This is the lateral. You can see this is the back, this is the side of a woman, and this is the X-ray tube is here, and it is producing the X-rays like this. But how the film is taken, you know the positioning, just bit of, you can see this patient in the PA position, which we have just discussed. And the tube should be 72 inches away from the patient to avoid the magnification. In the supine position, when the patient is not able to stand, he is not comfortable, or because of illness, we take the X-ray lying down in supine position. The X-ray tube is 40 inches from the patient. Lateral, we have just seen, and we have discussed this is a normal lateral film, which we will see lateral. Decubitus position. This is one position when somebody, if you want to assess the fluid in the pleural cavity, we ask the patient to lie down, and the side which is affected is in contact with the table, and we put the plate in front and take the X-ray. This can pick up a small amount of fluid. So whether the pleural effusion is mobile or loculated, fluid थोड़ा कम है ये ज़्यादा है, ये अपन थोड़ा सा minimal fluid can be detected in the decubitus position film, which we can miss in the PA view. Lordotic view, sometimes what happens, the clavicle and upper ribs, ऊपर की ribs or clavicle overlap. To separate them out, we take a lordotic view. This is how it is taken. It is a question of 60 seconds only to identify and quality assessment. You can see the right or left of the patient which is quoted in the film, and you can see the number. You can put a number. When the entry is done at the reception or at the counter, registration counter, they give a number. We can put a number here, and this identifies this film belongs to whom. And in 6, you just assess. You can see that it's been taken properly. Is labeled. His name, age, and sex can be written. What are the criteria? RIP means we have to see rotation, inspiration, and penetration. This should be the basic assessment, because if the patient is rotated, we might misdiagnose things. So this is a spinous process, and this is the medial end of the clavicle. Should be equidistant from the spinous process on both sides. You have to ask the patient to take a deep breath and hold it, and usually up to 10th rib is diaphragm level should be at the 10th rib usually. But sometimes you require to take an expiration film, which we will discuss sometime. What are the conditions where you require the film expiration film? But usually it is not required. Penetration. It should be adequate enough when we able to just visualize the lower thoracic vertebrae, not in detail, just you get it should be visible through heart. So we can say it's adequately penetrated. Because if it is not adequately penetrated, we might miss many things. Completeness. There should be an area above, an area behind, lower to the diaphragm should be seen. So you must ensure that everything in chest is adequately visualized. That is the completeness. Then we must we discuss how the image is formed. That is very important because there is a 5 X-ray densities like air, fat, soft tissue, bone, and metal. Air will be a black, fat will be a little gray, soft tissue is still softer, and bone will be white, opaque, and metal will be very bright white. So you can see here, it is all seen here. You can see the lungs black. You can see clavicle and scapula. The students of anatomy, they've been taught these bones. So scapula, clavicle, this all seen, and this is a metallic. So there are various densities are there. They produce the different picture, and that is how the image is identified and how we go to it helps us in the diagnosis. Now, how to read? We have to decide anything we do to do systematic. We form a system. You will see like this in patient's examination also, in taking history also. So same with the reading X-rays. So we can start from outer to inner side. You can start from outer to inner side. That is from the periphery to the center. Like here, you can see these bones, humerus. There's some white areas and black areas, radiolucent and densities, radio-opaque areas here in the ribs. So if you start from outer to inner, you're not going to miss anything. आपको से कुछ छूटेगा नहीं. Because what happens when you start from the anyhow you are going to, when you take an X-ray chest, you are going to read the X-ray lungs. So why not to start see the neighboring structure which is visible in the X-ray, and so we start from outer to inner area. Sometimes what happens, you see air in the subcutaneous tissue. This is subcutaneous emphysema. This can be also seen, and we must be very sure when we do an X-ray of the female patient, the hair should be out of the lung field. Otherwise, what will happen? It will produce an image, it will produce a shadow, and you'll get confused. What is this? So you must take care of that. Then we must go very systematic examination, because what happens if you're not systematic, we might miss anything. As in this case, we just did and we find a consolidation here. But in a casual reading, we will miss the lesion here. So this was a dislocation, and patient has the patient who had a recurrent dislocation of shoulder. They have with minimum trauma, they dislocate the shoulder. So in history, just before the X-ray was taken, his shoulder was dislocated. He was not having much of pain, so he did not complain anything much. And in this examination, we could find out. So we should do from the periphery to the center. And here, what I want to show you, we go. This is an airway. You can see in the center trachea. This is the right main bronchus. This is left main bronchus. This is the carina. The angle should be 60 to 100 degree usually. But if there is any pathology here, like lateral enlargement, lymph node enlargement, atelectasis, this angle increases. So we have to assess this angle. What I want to emphasize on here, begin the PA film, upper lobe and middle lobe and lower lobe. Middle lobe and lower lobe, right, overlaps. So in the same, in the left lung, upper lobe, lingula and lower lobe. So this is not, localization of the lobes becomes difficult only in the PA view until unless you take a lateral film. So for our convenience, we divide reporting into different zones. Only if we have taken only a PA film, so we'll write upper zone, mid zone and lower zone. Above second rib is upper zone, second to fourth rib is mid zone, and fourth to diaphragm is lower zone. So in writing report, we can mention this, which zone is involved. But if you take the lateral film, the things will be more clear, because here the overlapping area separates, because upper lobe is above the horizontal fissure and lower lobe is below the oblique fissure, or in between horizontal and oblique fissure, you see the right middle lobe. So for taking a lateral film is essential many times, and one should do it, because what happens is human body is in 3 dimensions. Just taking one view will not reveal all the dimensions. So you have to take 2 views at least to get the proper localization of the disease. Same with the left lung, major fissure. Above that is upper lobe, and below that is lower lobe, seen in this picture. And lingula is below the cardiac notch is seen here, corresponds to the middle lobe of the right lung. There's a PA view. You can see trachea, you can see carina, aortic knob, left hilum, right hilum, and diaphragms, and a gastric air bubble. We were very much surprised when I joined medicine, MD. My professor diagnosed the fundal carcinoma looking at the PA view. So we were just shocked how he could diagnose it. He could only locate it because of the disruption of the gastric air bubble. He raised a suspicion, which was confirmed in the later investigation. So this is what you look for, the surroundings also. And you see sometimes the mastectomic patient, one breast is missing, so you're able to know in female patients. The lateral film, the lung apices, esophagus, trachea, sternum, the ribs, you can see the heart, and these are thoracic vertebrae. So this is the hilar region. So it always necessary to have both the views. How to count ribs? We can count it. This is the anterior end, seen very nicely. This is the posterior end, connected to the vertebra. So you can count like this. These are the 6 anterior ribs, anterior part of the ribs, and this is the posterior 10th rib. So you can count either way. You can count like this, or you can count like this. So you can count and you can write. You are counting the interior part, or you are counting the pressure. How to count ribs? You are counting the anterior end or posterior end. That is important. Then why we need a different views? Sometimes what happens, just as this in the PA view, you are getting some haziness here in the lungs. This part is hazy. But if you take the lateral film, it becomes very clear that this was a case of an interlobar effusion. You can see clearly the effusion. This is the radio-opaque area, very well defined. And this is not giving a very clear clue of what it is. Again here, haziness here. And if you do an lordotic view, you can see a very much is fissure collection in the oblique fissure, effusion in the lower end of the oblique fissure, which is just creating a haziness here. So sometimes you need a different views, and it gives an additional information. So one view is not sufficient. This is a PA view, is looking normal, but the decubitus film definitely reveals is a pleural effusion, because up to 50 ml fluid also can be detected in the decubitus film. Of course, sonography is more sensitive method of detecting pleural collection. It can detect 5, 10, 15 cc of fluid around. So very early effusion can be picked up by sonography, but lateral decubitus film is also very sensitive, and it can pick up 50 ml of the effusion and 100% in 100 ml. There is sensitivity and specificity. So this is a good method of when you are in doubt and PA film not revealing, either you go for sonography or take a decubitus picture. AP versus PA, we can assess, we know this is the AP view. The heart is magnified. The ribs are clearly seen. And this is PA view. The normal cardiac shadow is seen. There's no magnification. Here, the scapula is overlying the lung field. Here, the scapula is out. The clavicle also, apex of the lung field in AP view and in the PA view seen over the lung field. That is how you can differentiate AP versus PA view. Hilum, left hilum is higher, right hilum is lower. It contains the pulmonary artery and these other structures, and was can sometimes seen in a large lymph node or a mass in the hilar area. So check the position and size bilaterally. You can pick up the calcified nodule, mass lesion, and pulmonary arteries if greater than 1.5 centimeters. Possible cause of the enlargement we can think and do other investigations. Which diaphragm is which? Want to know? It is very clear when the site is written. This is the left side, right side. This is the left hemidiaphragm, the right hemidiaphragm. Lateral film also. Lateral film, you see the chest diaphragm. The air bubble, stomach bubble is just below the left diaphragm, and right hemidiaphragm is in a higher position. It is more, right diaphragm is a little higher than the left diaphragm. Sometimes the diaphragm is not distinctly seen, so you just suspect some pathology. Can be infiltration, effusion, can be palsy, and other things. After seeing this all, we must review the areas and potential blind spot. Because the lung apices where the clavicle and ribs overlap, hila, retrocardiac region, because of the superimposed cardiovascular structures, we must review this area. After reading the total X-ray, we must reassess this area. Is something left out? Then we just go about cardiomediastinum. This is the cardiac shadow, and this is the mediastinum. This is the airway, and this is the lungs. So X-ray chest is a very good example of a contrast, because here there's a black area, here there's a white areas, making a contrast for the forming a good image. And here you can assess the thorax, and cardiac shadow should be half of the thorax. So CT ratio we can assess. Mediastinum will not discuss much about, just above the sternal angle superior, this is the inferior, and it divides in 3 parts. Why we should know about mediastinum? Because this is the localization in the lateral fin. I'm not going to tell you all details because it will take a longer time, but it helps in localizing the disease. In which part, which area, what, like in the posterior mediastinum, neuromas and other places are there. So this is a separate study, and we have to discuss sometime later if time allows. This is we all know, have gone through. Check gastric air bubble. We are able to see this gastric air bubble. Sometimes you see free air below the diaphragm, which indicates the perforation. And this is very important because in acute cases, along with the chest, along the erect abdomen, we must take the X-ray chest also, which delineates the diaphragm very clear, and you can localize the minimal free air. This is a massive, this is opacity, white lung, the opaque lung, and what are the different diseases we can present the same way. Like this is a consolidation, this is collapse, and this is effusion. Consolidation, you can see the radiopaque areas with the air bronchogram. Collapse is again opaque lung, but the mediastinum is shifted towards the same side. Fusion, again the opaque lung. The mediastinum is shifted to the other side. Then just a little bit of is very common pulmonary tuberculosis. Most common term is used is you get infiltration, and this sometimes the linear shadows and involving apex and midzone area. It is very common. and it is rare in the base involvement. In some females patients, you can see the same pattern in the bases also. Then we just assess the cavities. This is thin walled cavity, usually seen in the tuberculosis. This is thick walled with a fluid level. This is seen in the lung abscess, and this is irregularly walled inner and outer wall. This is seen in the neoplasm. This is the picture seen in the children, usually hilar nodes enlarged. This is the primary tuberculosis. I'm not going to details because it will common to discuss and a common chest solutions. We require a separate session. So I'm just ending up here with the note that is, we must know go systematic checklist, checklist, what you have seen, put the okay, and must keep the clinical pictures in mind before concluding. So thank you very much for patience listening, and we'll meet after a break if for the further series of chest X-rays skygram.
Thank you, sir. Sir, I have a few questions. Shukla sir.
Yeah.
I have 2 questions, sir. Can you please enlighten about Sylvit sign?
What?
Can you please enlighten about Sylvit sign, sir?
Select sign. Yeah. When select sign is when the middle lobe में pathology हो गया, the cardiac border will not be seen.
Sir,
here there is a select sign and spine sign. When there is a overlap opacity होगी the middle lobe पे, it will cardiac border will not be seen. And
sir, one more thing. How can a new doctor who has never seen much X-rays before, how can he differentiate between massive collapse and this massive pleural effusion?
As I told you, massive collapse में there will be shifting of mediastinum, है ना? Or in the effusion में there will be shifting of the mediastinum to the other side. So you can very well differentiate the massive collapse and massive effusion.
Sir, I request Dr. Lucas, sir.
Sir.
Dr. Shukla, very appreciable presentation from your side.
Thank you very much, sir.
I will appreciate that when we were UG student, we have never been taught in this way. What you have taught right now. Because you initially started with the normal thing, how it is, what is the views, different views to be taken, and what is the normal picture of the tissues and the different densities of the different density tissues. Once UG student is aware of the normal finding, then he will be able to detect abnormality. Yes. That is important thing. So that part you have covered very nicely, and I will like that this type of this session, whatever we are having, we should make a library of this. कि सर आप लोगों का जो प्रेजेंटेशन होता है उसको हम लोग को भेज दें, तो हम लोग सीडी करके उसको हम लाइब्रेरी में रखना चाहेंगे, और जरूरत हुआ तो उसको कभी हम दूसरे इंस्टीट्यूशंस के लिए उसको हम अवेलेबल कराने की कोशिश करेंगे सर.
It will be our pleasure, sir.
नहीं बहुत अच्छा जो भी सेशन मैं सर, क्योंकि मैं भी सर्जरी साइड से हूँ, तो थोड़ा सा क्लिनिकल इंटरेस्ट तो रहता है. पिछले बार भी जो स्नेक बाइट का मैं बहुत इंटरेस्ट से मैंने अटेंड किया था, क्योंकि ये हमारे यूजुअल टॉपिक्स नहीं रहते सर, जो जैसे स्नेक बाइट्स वगैरह. तो हमने भी कल वो पिछले बार जो डॉक्टर कुटे ने प्रेजेंट किया था, तो मैं उसको अटेंड किया था. तो बहुत ब्रीफ में बहुत ही डेप्थ का जो बेसिक जो चीज है वो बहुत फंडा क्लियर हो जा रही सर इस तरह के सेशन से. तो ये जो मैं चाहूंगा सर कि इस तरह का जो आप लोगों का प्रेजेंटेशन है उसका हमको सीडी में या इसमें किसी में अवेलेबल कराए, तो उसका एक हम लाइब्रेरी बना लें सर उसको.
बिल्कुल.
और इसको सर जो रेडियोलॉजी से रिलेटेड आगे का कुछ सीरीज इसमें रखना चाहेंगे सर.
सर
बिल्कुल सर. सो नाइस. It will be my pleasure.
If the demand from the student comes, then we will have second session of X-ray chest. Otherwise, we have planned X-ray skull, because road traffic accidents are very common, and at casualty the X-ray skull जो है उसको evaluate करने के लिए हमारे जो young doctors हैं उनको थोड़ा help हो जाएगी. तो
definitely.
For the next session, I request Lucas sir to be chairperson of the session, and he always attend all the session. But for next session, because he is from surgery side, a renowned surgeon and the institutional head now. So in the next session, he will be chairperson. Any other person wants to have any question with Shukla sir? He is ready to interact with student.
Sir, good afternoon. The informative lecture from your side. My question is, sir, how you differentiate between the X-ray VA view and AV view?
What you asked? PA view and
AP.
yeah, I showed you that AP view mein the scapula will be inside the lung, and PA mein the scapula properly positioned will be hanging outside, and there will be magnification of the heart in the AP view, and the ribs will be very distinctly seen in AP view, whereas the PA view the ribs will not be that seen. Sometimes in AP view, in trauma cases, we ask for an AP X-ray along with the oblique X-ray also. Oblique view to see the angle of the ribs, we do an oblique X-ray also. So AP view is, of course, I showed you. I can show you the slide again if you want it. You want it, which I differentiated the AP and PA view.
Students are requesting to have slides, sir, so you can
Yeah.
and give. We can share to this can be shared with email only, and with the official communication to the hub, they will get on their email, because its size is big. Whatever you share, sir, and we will inform whom we have.
Definitely.
There is one request that please have one session for reading TV X-rays. So I would request that one you to please prepare one presentation for reading X-ray in TB cases also, sir.
Sure.
Have it here.
Sure. Because tuberculosis is very common, and
yes,
we have all cavitating lesion, infiltrative lesion, and there is a chronic pulmonary tuberculosis. The sequelae of events which manifest in the X-rays, X-ray chest will do it that. Sure.
Dr. Komal Meshram from Shankara Medical College, MEU coordinator, are you there? Want to give some input, or we can continue?
Yes, I'm there. I've heard the session and it is very nice. I think all the students should get benefited with this type of presentation. Thank you, sir, for presenting such good presentation.
Thank you very much.
Sir, with this we are concluding the session, sir. Thank you.
Okay, thank you, sir.
Thank you
very much.
Thank you so much.
Yeah, thank you, sir.
Thank you, sir.